Today's fair is a day full of events. So we'll start first with a powerful panel discussion about leadership in crisis, followed by a keynote presentation on innovative ways to promote staff engagement in quality and patient safety activities. Both events will be held in this auditorium. Afterward, we'll move to the Fab Hall in the Public Health School to attend the poster session and the breakout rooms. Those breakout rooms will be discussing innovation and AI, culture of safety, Joint Commission tips, patient experience initiatives, and impact of care management on quality and patient safety. Then we'll have some kind of break and refreshments back here in this area, and followed by oral presentation on 4 impactful PI projects. We will conclude the event with an announcement of the winners for the posters and the oral presentations. Thank you all once again for being here, and I look forward to a great day ahead. If you have any questions or if you need any more information, our team will be around to answer your questions. To kick off today's Patient Safety and Quality Fair, we are excited to present a panel discussion on leadership in crisis. Healthcare leaders are often faced with unprecedented challenges, whether it is managing a pandemic, responding to cybersecurity threats, addressing financial challenges, or navigating other crises. Effective leadership during those times is critical to ensuring safety and quality, not just to the patients, but to our staff. Today, we will explore how leadership responds in times to crisis, the strategies used to maintain high standards of care, and the long-term impact of such challenges on healthcare systems. We have leaders from across New York City and New York State, and I'm pleased to introduce the moderators for this event, for this discussion. Dr. Cynthia Benson, the Interim Director of Emergency Department, Jamie Grecco, our Chief of Human Resources and Interim Chief of Staff. Both Cindy and Jamie bring valuable perspectives and expertise in this conversation, and I look forward to having the insights that will guide the panelists through. Thank you very much, Dr. Benson and Jamie. And I'll invite our panelists to the podium.
Good morning, Downstate.
Morning.
Let's get started. I'm excited for this conversation. Mr. Doyle, this first question is going to go to you. Literature has shown that environmental disasters impact medically underserved communities disproportionately than other communities, and that's due, theorized, to a lack of public health infrastructure. So we know that's a fact. However, when disasters are planned for and surge capacity is planned for, the fact that there are healthcare disparities is not usually kind of built into the programming, knowing that some communities are going to require more resources. So given the fact that we've had such a significant increase in domestic natural disasters, such as wildfires in Hawaii, in LA, in Canada, in New York City, New Jersey last summer, as well as the hurricane, for instance, that devastated the Baxter plant, are there any proactive strategies, such as IV fluid conservation or things in that nature, that organizations should implement now in order to minimize the impact on operational processes in case there is a disaster? And as you plan for institutional or system growth, does the level of disparity in a medically underserved community alter how or what you plan, or should it?
Okay, well, thank you for the question, and thank you for inviting me here this morning to speak and participate in this panel. The question posed about disparity and how that orchestrates response to disasters. We, in healthcare, we know this, I'm sure this room is well aware that preparation and response are how we manage disaster. Or unforeseen events when it comes to disruption of our healthcare delivery system. It's important to maintain the level of safety and quality to the healthcare system, to our patients, for our staff, and to what we deliver each day, even when facing unexpected events such as disasters. Ways to prepare and begin to reorganize our healthcare delivery system in various regions throughout the country. In New York City, is an area in Brooklyn for sure that we working here for some years now, almost a quarter of a century, actually 25 years in Brooklyn in partnership with our colleagues here, some at the table. Coalitions are very important. Establish true coalitions, collaboratives. We have those in Brooklyn. Those are sometimes required by Joint Commission and New York Department of Health and Mental Hygiene that we participate in drills. We participate in communication drills in addition to scenarios presented by the various organizations, and we collaborate on those on a coordinated, routine basis throughout the years. These are scenarios that are presented. Mass casualty typically are the scenarios that are presented in this region, as well as communication failures. Some are we're beginning to turn a mind towards supply chain, and we remain vulnerable. I think system approach, being part of a full system and having the support of a healthcare delivery system, not being a standalone hospital that's relying on coalitions that are less formal than obviously than being part of a system can mitigate or help manage that. So the stronger we are regionally as partners and work and collaborate and support our colleagues and our partners in coalition regionally, as informal as those are, until they become more formal and required, is a way to begin to prepare for that. Managing when you don't know what's going to happen, like preparing when you don't know what's going to happen, can prepare us with, cause us to be ill-prepared. We're reactionary when it comes to what happened with the IV solution specifically. Having the team review the processes and be able to communicate throughout and clearly with the entire care team and communicate any change in the process as we make those changes to the delivery of care. Managing the IV solution is again another example that we're familiar with. The medical teams work very closely on how to repackage in certain ways safely and how to reutilize or how to utilize volumes or packaging, and also how to conserve. And we realize in healthcare we waste a lot. We have a lot of waste in our system of just materials. We look at our prep in our ORs, and we look at what's laid out in those areas. So managing waste in our systems and having an approach on our infrastructure, our generators, our ability to support ourselves when we have power outages or affected by other natural, we'll call them disasters, that seem to be way more frequent and seem to be impacting us more and more. And again, going back to the top, we're required to be prepared in order to provide the safe, quality, consistent care throughout an emergency. And we've seen examples of that. Best ways are to drill and have collaborative coalitions when there is no formal health system in place in the region. And we can, draw, any, sort of examples of that from our local region, et cetera, who's more advantaged and who is less advantaged when it comes to that. But certainly the systems, the stronger, bigger systems have advantage over certain other parts of the local region. So I'll pause at that. I don't know if that helped. Was that?
Yeah, no, that was great. I think picking out some themes, it's important to have, I think we're going to see these themes throughout the panel, but important to have good communication, to prepare by drilling, because that's how you kind of cement the action that is to be taken, and then just identifying and decreasing waste as much as possible in advance of a disaster so that you have more on hand.
Right, and to speak to the purpose of the panel of leadership throughout a disaster and a point is right. Communication with the team, being present, rounding from leadership rounding when we're faced with external pressures and sometimes internal is so key. Been available, senior leadership, been available on the floor, been able to communicate consistently and regularly the status the emergency. We have to remember that our staff can be impacted outside of the workplace by these disasters in some scenarios, by the storm, Superstorm Sandy, et cetera. The staff were impacted by that, not able to get gas in some ways to get to work, or some people's homes were flooded in various parts and impacted by that, and their families throughout the local region. So supporting staff with information consistently and with presence and executive leadership and leadership presence is very, very important throughout that. I'm sure we'll talk about that as we talk through other parts of the panel discussion this morning.
Excellent, thank you. Mr. Grecco?
Thank you. Dr. Winston, this question is for you. Regarding infection, COVID, avian, RSV, flu, measles. An April 2021 Lancet article stated that two of the biggest drivers of reemerging infectious diseases are social and health inequities. Data show that low-income and high-minority prevalence areas like Brooklyn were the most devastated by COVID-19. So, how does prior pandemic experience inform decision-making for the next pandemic, given that one doesn't know what will be needed? Are there best practices that can be applied no matter what infection is at hand?
Thank you for the question. When I was asked to be on this panel, it brought back our COVID experience here, and many of you were a part of it. I think as a result of what we went through, preparedness and accountability are key to saving lives, and that'll work for any pandemic, you know. And I'm sure nationally now we're calling, you know, we have a pandemic playbook that people are playing by. But some of the key things I thought, and I'll compare that to what we did, you know, early detection and surveillance is one. You know, having global and local monitoring, genomic sequencing, that's what helped them get the vaccine developed so quickly, even though some people didn't trust it and thought bleach was better. But, you know, there were different things that, you know, were important to us. And transparent data sharing, rapid response and containment. You know, we're in an old facility. Many of the facilities in Brooklyn are old, so we don't have all isolation rooms. And I remember the plastic we used to isolate our patients. And that's important, to isolate and quarantine and do contact tracing. That's what helped South Korea contain their virus, because they did contact tracing. And we got through that. And let me just say, all of these things I'm talking about, we did pieces of here, but we did it as we were going, not really knowing what we were exposed to, but just working very hard together to figure out what the heck is going on. Travel policies, you know, everybody knows they put travel policies in place. PPE and supply chain readiness. Now that part was very scary. We can say stockpile, but this stuff expires. You know, so you have to have a supply chain that has those resources and use those supplies. If not, they're going to be out of date. And I remember we went through this, and we had to have the city or state said we had to have a 90-day supply. We had to turn that over. The other thing we got lots of supplies because people pulled together and they wanted to, but they weren't hospital grade. You know, so what do you do with those? You know, you use them for teaching and that kind of thing, but we got enormous amounts. Now, we couldn't let the public, and we stored it, because we couldn't let the public think we weren't grateful and that we didn't want those supplies, so they couldn't see that, you know, we couldn't use them, but you don't put them in the trash bins. But, I mean, that's real important, to figure out how to manage the supplies when something like that happens. Hospital surge capacity, you know, healthcare system preparedness. Until that hit, I didn't realize how quickly you have to move in that environment. We were designated COVID only, so we had to get all the healthy and close to healthy out of here and prepare COVID hospital. We had to just have every room, every space we had, and we were asked by the state, it's kind of disjointed a little, you know, to prepare so many beds. And they said they'd help us stand these beds up. Now remember, these are semi-private rooms, and that really didn't happen. The ICUs are open, so they promised that. That didn't come to fruition. That's why we had to use the plastic, but you just learn and do as much as you can. During that time, cross-training the docs. We had docs from all different specialties helping to take care of these patients, and it was scary. And Cindy, you remember, I mean, you were a part of that. We had all kinds of physicians trying to help us take care of these very, very sick patients that we didn't know what was going on with. We had families scared to death. We had a big room full of valuables. People thought they'd catch something, so they, wouldn't come and pick up the valuables. And at some point, we had to get rid of all that. I mean, it was a scary time. Telemedicine, we got into that business. And that's, during COVID, that's when telemedicine skyrocketed. I mean, and it's important, and you use it now, it's a good thing, but it took COVID to say, guys, think there's another way to, whether it's educating people in school, whether it's seeing sick people, or however you do it, you can do it that way. Meetings, now some of us enjoy it so much, we're having a slow time coming back to the office. However, it works. Public health communication. All of you were a part of this. I mean, and I'm sure it'll be, well, I'm not so sure it'll be better going forward, but, consistent scientific-based messages to people to say, what should you do during that time? Not just, everybody, doing whatever. Engaging community leaders and influencers, people that people listen to, people that look like you or act like you, to tell you, it's important to wear a mask. It's important to get a vaccine. It's important to be safe. If you don't want the vaccine, just try to be safe. Encouraging, having people behavioral health guidelines, like, if I get to know you and I know you, you'll listen to me and you'll do what I'm doing, and to have those kinds of things happen. And the other part of behavioral health is to have people available to help people through all this. I mean, and that's terrible. And that, I think that's kind of the biggest fall down for me, because people are still suffering. People are still scared. I mean, listen, I'll whip out my mask in a heartbeat. Even look like you're going to sneeze, and I'll grab a mask. Vaccine development, having these, they said in the literature that the way we were able to manufacture that COVID vaccine, again, that people thought was suspicious, was using adaptive vaccine platforms. They called it mRNA. And that enabled us this time to have the COVID vaccine, and we need to make sure we have those so that we can do that going forward for future whatever happens, whether it's measles or whatever. And I'm not a scientist, so I don't know that part. Regulatory pathways. Streamline the approval process for who can do what. You want to keep people safe, but you want to be able to bring in healthcare providers, and we had some of that to come in and help take care of these patients, because you approve it really fast. And global distribution of vaccine. We weren't, some people got, some people didn't, but to make it equitable so that you don't have these variances, these vaccine variances emerge. I only have a couple more, so then you can take a break, I guess. Breathe. Economic and social support. We talked about remote work and education. We didn't talk about mental health resources, for stress, burnout. I mean, look at the pictures that were on the news for how people looked and they were tired and exhausted. International collaboration, with CDC and WHO as we know them now. And regional alliances to see what we can do. Legislative readiness, and that's a big one, so we'll see what happens. But these are all the kinds of things that will help us be better prepared going forward, knowing that, having lived it, and knowing these things will make us better for the future, hopefully. Thank you.
Thank you.
So you did hit on the communication theme, which I think is going to come out of this. Also, I picked out innovation in a couple of different ways, both in the scientific community, utilizing healthcare delivery systems a little bit differently. But I also like that one of the takeaways is going back to the basics with something as simple as contact tracing, not that it's simple. In principle, something as simple as contact tracing that becomes a very effective strategy, especially when there's an unknown thing that we have yet to fully figure out. So I think it's kind of you pulled out a nice blend of some of the tried and true strategies, but also challenges to be creative and problem solve in innovative ways with good communication around all of that. You'll see this is definitely a passion. Okay, Dr. Wei, next up. So in 2022, the Surgeon General published an advisory titled Addressing Health Worker Burnout, the U.S. Surgeon General's Advisory on Building a Thriving Health Workforce. In that paper, there are some statistics listed stating pre-COVID, so before any of the pandemic hit, 35 to 54, not 55%, of nurses and 45 to 60% of medical students and residents reported burnout, which, as you well know, is an occupational syndrome characterized by a high degree of emotional exhaustion and depersonalization. So the question for you is, you've demonstrated through the creation of H3, Helping Healers Heal, that staff wellness is mission critical for any institution. Given that post-pandemic staffing is one of the greatest operational challenges we all face, are there other strategies that can be employed to improve staffing, retention, and engagement? And are there different strategies to address leader burnout, or are the strategies employed there the same as frontline staff?
All right, thank you so much for the question, and thank you for having me here for this panel. Wishing all of you a happy Patient Safety Fair. I feel like I'm cheating a little bit on this question because I was in DC yesterday at the National Academies of Medicine, and Dr. Murthy actually spoke there as well. But today is actually the second annual Healthcare Workforce Wellbeing Day, and so wishing all of you a happy day for that as well. But I think what the panels yesterday that I took part in really drove home is we've come a long ways. Just the fact that there is recognition, there is the Surgeon General's map or roadmap for this. National Academies of Medicine has also created a playbook for any hospital, clinic, health system that wants to address clinician well-being. But when I started helping Healers Heal a little over 10 years ago, there wasn't really a blueprint. We really had to build it from the ground up. And for me, it was when I first became the deputy CMO at LA County USC, and they said, congratulations, now you have to run our RCAs. I had never been to a RCA, I had no idea what RCA stood for. Somebody told me it meant root cause analysis, and so I went to Google. I typed in how to run a root cause analysis. But the first one really left me kind of shaken with a pit at the bottom of my stomach. We brought nurses, we brought residents, we brought attendings to tears or the verge of tears, reliving a nightmare case of theirs that's probably caused them to not sleep, to not eat, right, to constantly be replaying this case over and over. And then we would pat them on the back after an hour-and-a-half meeting and say, now go back to the operating room and do perfect surgery, or go back to the ICU and pass meds perfectly. And I knew, they knew, everyone in the room knew they couldn't do that. They were compromised, right, because of second victimization. And so looking around the country, I was like, there's gotta be, right, a model out there for us to create something to better support our staff, and there really wasn't. And today there is. So we've come a long ways. But yesterday also really drove home that we have a long ways to go. We are in an existential crisis with burnout of all disciplines in healthcare, right? How we're already at a staffing shortage, going into the pandemic, and it's exacerbated by people saying, okay, that was my last rodeo, I'm retiring, or I'm gonna find something else to do. So we all know how hard it is to find nurses, to find physicians, respiratory therapists, even lab technicians. And so we're in an existential crisis because if we don't change paths, we're not going to be able to keep all the hospitals and all the clinics open. And so first, I think is acknowledging that we have a problem, not just a problem, a major crisis. I think as a leader, right, the most important thing is kind of swallowing that ego, admitting that you don't have all the answers, and having the humility to ask all the people in this crowd, in this audience, all the people that work in this hospital, you know, what do you need, right? I think there's a few buckets, I would say, that could kind of turn the tide. So one is addressing the anxiety, the stress, burnout, the mental and psychological toll, and being able to provide support. So H3 is based off of the concept of we give our patients and their families our healing powers all day, every day, freely, right? But the culture of the House of Medicine almost made it impossible for you to give it to your peers. Nurses eating their young, right? The attendings telling residents that I walked barefoot in the snow uphill both directions to the hospital and worked more hours in the week than there are in the week. So what do you have to complain about of your duty hours, right? We need to change that culture of the House of Medicine to be able to turn that healing power towards each other, right? I've been told way too many times that don't we give them good health insurance? Don't we have an EAP program? Like, why do we need more, right? Imagine being in a dark place, maybe even signs of depression or suicidal ideation, and being told, call the number on the back of your insurance card, right? That's just not good enough. So programs like H3 to address the emotional and psychological support, there needs to be system work, right? There's no amount of yoga and meditation that's going to make up for the moral injury, for the burnout, for the stress, the anxiety, the compassion fatigue, right, the vicarious trauma that we accumulate working in healthcare. The things that we see day in and day out are not normal. You don't talk about that around the, you know, at the restaurant with people who aren't in medicine, right? And so being able to put programs in place that are proactive, that address the 8 dimensions of wellness. You know, not everyone's going to need all of those, right? But making it available. But most of this is systems work, right? Why does somebody like my wife have to go home and after all of our kind of putting the 3 kids to bed, whip out her work laptop and have 2 to 3 hours of epic pajama time, just so that she doesn't carry notes into the next day, right? Can AI help us here? Is there technology that helps us not have to spend so much time typing, right? We didn't go to medical school, we didn't go to nursing school to be typists, right? And so can AI listen and be able to create our notes and our orders for us? I'm really excited about this ambient listening opportunity. Another thing that's really frustrating, it leads to a lot of patient safety and quality events that are traumatizing, is somebody is complex, they have a really, really large record, right? I have about a minute before I go see that next emergency medicine patient or emergency department patient. It's just random if I pick the right notes to open, right? Can AI summarize all of that into one paragraph for me and say, this is the most important things out of these thousands of pages of notes that you need to know before you see this next patient, right? And so we need to use what's worked for quality improvement for addressing patient safeties, like reducing CALDs, CLABSIs, falls, pressure injuries. We need to use that same rigor and that same engine and apply it towards what's burning out our staff, right? And then really listening to our staff about, you know, what would they like to see changed, right? But I think it's the leadership lesson here is swallow your ego, have the humility, have the listening sessions, have the uncomfortable, difficult conversations, and through that, let's partner together to make this better.
Excellent, thank you.
Okay, Dr. Scott, this question's
It
for you.
must be me next.
Okay. It's well established that medical reimbursement does not fully cover the cost of care, and we all know that. With safety net hospitals often facing significant financial challenges, especially during times of crisis, what leadership strategies can be implemented to ensure that these hospitals remain operational and continue to provide essential care even under financial strain? And how can leaders balance fiscal responsibility with the need to maintain quality patient care during such a crisis?
Well, that's literally the $2 billion question, isn't it? Thank you for the question, and thank you for having me. And I want to take note that there are 3 emergency physicians on this panel, which is in and of itself, in my lifetime, a remarkable change and leadership in medicine. So I want to start off by saying the most important thing, and you framed the question around safety net institutions, so I'll frame the answer in that way, is to stay close to your mission. Human beings need purpose. Organizations need purpose. So one of the most important things a leader can do is to ensure that the workforce, the organization, understands its purpose. And once you understand your purpose, that helps to drive the operations to deliver the service. We are in the business of providing service to improve the health and wellness of the communities we take care of. And at the heart of that care is patient safety and quality. So at the end of the day, institutions need the community to choose to walk through our doors because we're in the business of delivering healthcare. So like any other industry, we want our customers to choose us. We want our customers to have good service, good outcomes, and to be happy with satisfied with the services that we provide. That leads to financial stability and wealth. So even if the reimbursement from Medicaid remains less than $1.20 on a dollar, right? Even if it remains at 70 cents on a dollar, 65 cents on a dollar, if the community is choosing to walk through your doors and they're receiving quality care and they're satisfied, they feel heard, they feel seen, they feel cared for, then you're providing the service that you aim to provide, right? And at the end of the day, if you're able to do that as an organization, then those in the state, federal, and city government will support you, right? So if you're chosen by the community, you're delivering high quality, safe care, at the end of the day, you're not replaceable and you can't close because you have a purpose and the community is choosing you. I think that's extremely important. If you're requiring subsidy because of the way reimbursement is structured and the community is not choosing you, then you're in trouble. The institution is in trouble. So the next thing I would say, which is in line with what the other panelists have spoken about, is change is absolutely necessary. There's no avoiding change. We as individuals are changing every day. Our families are changing every day. Our communities are changing. The environment is changing. It's not about what if we have another disaster. We're going to have another disaster. We're going to have another disaster. That's the nature of the environment that we're living in today. Finances will change. Reimbursement structure will change. Therefore, the organization has no choice but to change. And I think one of the major responsibilities for leaders in healthcare is to shepherd organizations through change. The new buzzword for change is transformation. And in full transparency, One Brooklyn Health is under transformation. SUNY Downstate is under transformation. And that means, similar to how the environment is changing, you as individuals are changing, our political dynamics are changing, our organizations must change. We cannot continue to deliver healthcare in the same way we did 10 years ago. So if you look at your organization and you say, how can patients schedule appointments with us? And you look at what's the scheduling process? And you compare that to what you did 10 years ago. If there is a lot of similarities in how patients get appointments, they have to call, somebody has to answer the phone, somebody has to look in the computer system and find the next available appointment, right? Maybe you send a text reminder or not. That's a pretty old paradigm, right? To your point, how did doctors used to take notes? We saw a patient, and then we sat down, and we wrote people finally figured out we couldn't understand what the doctors were writing, so they made us type. Now we're typing more and more and more, and the typing is no longer feasible, so now we need technology, right? So doctors can't continue to document in the way that we did 10, 15 years ago, right? Ambient technology is one solution, but that's probably not the only solution. Right, that's probably not the only solution. We're finding a solution that kind of sort of does for us what we were doing in the past. But is there something completely innovative about the way we document a patient-physician encounter? Can we do something that's even more, innovative, right? Like, of the work, so you described having a ginormous medical record as an emergency physician that you're expected to review. The patient expects you to know everything in their medical record anyway, right? You're expected to review it, have the encounter, gather all of this information about the individual, put that on a piece of paper, and then carry on with your medical decision-making. But that seems kind of bananas to me, because the question is, what percentage of the information in that ginormous medical record is relevant, right? Some of it is relevant for regulatory purposes. Some of it is relevant for billing purposes. Some of it is relevant to communicate the patient's condition so that the next care provider can kind of pick up where you left off. But truth be told, most of it is repetitive and not actually relevant. Right? So what if we thought about, well, what is relevant, right? And what is relevant for the physician to document and the nurse to document? What percentage of what's documented by the nurse and the physician is the same thing, right? Every single person who's taken care of a patient has heard the patient say, but I already answered this question. Who hasn't heard that? Why are you asking me the same questions over and over again? That's a reasonable question. Have we answered that question? Have we created innovation so we can stop asking the patient the same question over and over again? Right? No. We're creating technology to do what we used to do, which is document the same, ginormous volume of a medical record. So I think to summarize for you, transformation is a necessary component of life. Change is a necessary component of life. Financial stability comes from effective business management, right? And for us, delivering high-quality, patient-centered care, right? Making sure that our communities choose us. And then, we have a responsibility to do the dance that we're required to do to get reimbursed for the care that we provide. So that's how I would answer your question.
Great, thank you. I picked a lot of things out of that. I think, again, there's sort of themes in all of these, but innovation, figuring out technology. I like the idea of not just using technology to do the same thing you did before, but actually using technology to be innovative, and then how you communicate that, obviously, throughout patient encounters, but throughout systems is an important lesson. And I really enjoyed that the leader's job is to shepherd organizations through change. I think that's kind of the key message in this panel, and then figuring out how to do that in the overlay of crisis, because I think the amount of change that we experience often feels like crisis, and figuring out when it is and when it isn't is a key mission.
So, I'm sorry, but is change really a crisis?
Sometimes.
Right? I mean, sometimes it is, but I think we think all change is crisis, oftentimes in healthcare, because we're so resistant to change. When someone imposes change, we feel like we're in a crisis. Eric?
No, on this change thing, somebody brought up yesterday that their favorite T-shirt is a Dilbert cartoon that said, "Change is good. You go first." Right? I just want to also add, building off of Sandy's comments and her prompt, New York City Health and Hospitals, when Dr. Katz and I joined in 2018, everyone was like, you're crazy. Like, this is career suicide. Why would you take over a failing safety net system? Not just a failing safety net system, one that's the largest in the country. And so H&H's budget then was $6.5 billion a year. It had a $1.8 billion structural deficit. That meant after all the subsidies, all the revenue, the city still had to come up with almost $2 billion to keep it from going under, right? All these consultants came in, multi-million-dollar analysis, right? Reports, close hospitals, stop hiring, backfilling staff, right? It's 80% of your costs. And so it was in this death spiral of, if you're not backfilling nurses and doctors and respiratory therapists, right, then you have nurses covering 20 patients, right? And then what kind of care are you providing? And as Sandy said, there's no glory in providing bad care, right? And no elected's gonna go to bat for you. But we actually closed that gap, even with the pandemic. We get $2.2 billion more in revenue today than we did in 2017, right? And it was from growing out of it, investing our most precious resource, which is our people, saying we have your back. You don't have to worry about this hospital closing or this clinic closing. Let's work together on the revenue cycle piece, right? Why is it that we haven't changed our reimbursement rates and we haven't sued United Healthcare and others that even with the poor reimbursement rates haven't paid us? And then what are business plans that we could put together that will help subsidize the other care that we know we can't make money off of, like behavioral health and so forth, right? And so we have very successful business plans across all of our hospitals that have helped create. So revenue cycle growing business plans have created $2.2 billion more in revenue. And so I think just because you're a safety net doesn't mean that there isn't a way to become kind of, in the black. Of course, we still depend on disproportionate share dish, on upper payment limit, right, and the support of our electeds for a lot of our capital things. But it is quite a turnaround to the point that the state's asking us if we want to take on more hospitals. So quite a story, and it shows kind of a lot of the things that Sandy was mentioning.
And that's a journey. That's a journey, yeah, that you have to be willing to take. Yes.
I'd just like to add to the comment about change. Change is change, and I agree with you, Sandy, that it depends. People are resistant to change, but also I think sometimes it can be chaotic when it's not organized. I'm not saying that you don't look at it, but if you don't have strong leadership and be focused and structure that change, it appears chaotic to anybody who has to respond to that. So I think that's more the thing. The chaos is created when there's disorganization.
I'll just add one thing that doesn't come up all. Go ahead. Yeah, applaud for that. Add one thing when it comes to change, but trust. People trust in change when they know the direction that the transformation, as the word and the popular word is for change at the moment. The trust when the vision is known, the trust when the values, as Dr. Scott mentioned, our mission, our values, are known throughout our organization. So we know what we're about, we know what we're here for, we know who we're here for, and we know that we're here together. And we can trust we're well fortified, we're well positioned, we're standing on a foundation of change that can be meaningful. And yes, there'll be bumps, and yes, there'll be uncertainties, but moving in that direction, moving teams in that direction, leading in that direction, if we can demonstrate and earn trust with our partners as well as our teams, then we're on to something.
I just want one last comment on this. So we have these disruptors. There is value in healthcare, and what we do, I call it a calling. We take care of people, we meet their needs. However, look at the CVSs and the other companies, especially out west, they've gotten into taking over facilities. H&H had a strategy, they worked towards it, and they did it. But out west, they're worried about people taking the business from their big systems that were cumbersome. So there are all kinds of people out there who are anxious to help, and of course the people like CVS and Walmart and all those people, I mean, they have the funds. We need to figure out how to grow some funds so we can take care of ourselves.
And I mean, I think another important point that the collaboration has to also be between institutions, right? So particularly in Brooklyn, I think a new paradigm has to be not just at this level, right? Because if you get us around the table, I guarantee you, we've already met, all of us, like what can we do together, right? So that we're not duplicating resources. Given the financial constraints that we're all under, how can we work together? Because our missions are aligned across all of the institutions that are represented here. We want to take care of the community. We want better health outcomes, right? We want to make sure that life expectancy is equitable regardless of your zip code. We kind of are all on the same page about that. So what has to happen for the financial viability of all of us is we have to work together. And that's new. Work together beyond this table. It means on your level, right? How can you spark an idea so that we can work together to deliver the service to the communities that we serve?
Excellent, thank you. All right, we have two more questions that are, does anybody in the audience have a question at this point that they want to bring forward? If not, then what we were going to do is ask everybody on the panel the same question. We're going to start with a definite hot topic item, which is violence. So AAMC News reported the Bureau of Labor Statistics, this was from, it was published last year. The Bureau of Labor Statistics showed that the rate of injury from violent attacks against medical providers grew by 63% from 2011 to 2018. We also know that there was a recent murder of a healthcare CEO, which displayed that there's a section of the population that is so frustrated with the healthcare system that violent extremism has become a concern for all of us. So how does these things change the quality of care that is delivered? And how can leadership in healthcare respond to this growing threat? Are there strategies that can be put in place to protect healthcare workers while ensuring that the violence doesn't compromise the quality of care that's delivered to patients? I think since we went this way, maybe we'll go this way, just to change it up, and the next one will come back around. So Dr. Scott, please.
Well, I mean, that's a very complicated question, because the increase in violence is due to changes in the dynamics largely outside of our institutions. And so that is going to necessitate collaboration with those institutions that help to control the dynamics in the community that result in increased violence that then bleeds into our institutions. But one of the things that is top of mind for me is reestablishing our healthcare institutions as sacred places, right? So churches don't have the same kind of problem. And I believe that healthcare spaces should be sacred spaces, and we should create that belief and comfort in the community so that they respect the healthcare institutions as their own home, right? And so, although some people are violent in their own home, but in general, you want to make sure that the community sees us as a safe place and they respect the healthcare institution. I think that's slightly at the heart of the problem, right? We know that there has been historically hospitals are not to be bombed during war, right? We have international policy that protects healthcare institutions. So why do we not have the same paradigm in our communities that we are serving? So I believe that a key component to reducing the violence within the walls of healthcare institutions is to change the perception of the role of the healthcare institution within that community.
Yeah, this is something that definitely keeps me up at night. And I remember, when we had the shooting in the Jacoby ED a few years ago in the waiting room, and the staff were very scared, and they were very honest on these listening sessions. And they said this should be a never event. Anytime a healthcare worker is, verbally or physically attacked, it should be a never event, and we should take it as seriously as the NIPORT's mandatory reportables to the state. We should be doing root cause analysis, and we should be looking at what the root causes are and putting in corrective actions around that. And so that is something that we're doing at Bellevue. I think many of our H&H facilities are doing it as well. I agree with Sandy that this is especially the emergency department is not just the safety net of the safety net, in our systems, but it's for everything that's broken in society ends up at our doors, right? We take everyone without exception. It's always open, right? And it is, right, severe mental illness, it's substance abuse, it's the stress of, right, socioeconomics, the pandemic. We say, right, it's caused people to be deranged in a way that there's this quick to violence, more than before, and we're seeing it across the globe. I was in Singapore a few years ago giving a talk, and toured their emergency department, and it's the same sign that we have in our hospitals there about not attacking healthcare workers, and so this is a global crisis. Some of the things that we found very helpful, we created a new discipline called behavioral health associates. So we have hospital police, but a uniform can be triggering as well, and it means different things to different people based off of their past experiences. And we have, right, physicians, nurses, psych techs, but everybody is really busy with all the other responsibilities they have. The BHAs, their sole responsibility is to monitor the therapeutic milieu of the unit and to look for agitation and escalation and intervene to de-escalate, separate patients that might be agitating each other, right? Warning leadership of that unit that, right, this is turning into like orange level or red level. This is a powder keg. It's something bad is about to happen. We need to take some proactive steps. And so having BHAs in places besides our psychiatric units, like our emergency department, our medicine wards, not so much in our ICUs. This doesn't tend to be as big of a problem there. But being able to kind of lower the temperature and de-escalate, talking to our residents, talking to our attendings, our nurses, they absolutely love the BHA program. Also, creating kind of standard work around what steps you're gonna take, all the way up to if you need to call a behavioral code, and what's everybody's roles and responsibilities, are using simulation to practice so that it doesn't go wrong, right? I've heard multiple times, 9 out of 10 times it goes great, but that 10th time somebody didn't know what their role or responsibility was, and a nurse got kicked in the face, right? Or a resident got punched as a result. Also, right, for behavioral health, there's mandatory training, right? The de-escalation training. We've created a shorter, abbreviated version of that, 4 hours rather than 2 days, that we're putting all of our emergency department staff through, and then we're gonna move to medicine and other specialties as well. We found that to be beneficial as well. They're speaking the same language as the BHAs. They're speaking the same language as our psychiatrists.
I agree with both of you, all the things that you've said, and the BHAs, as you call them. I've worked in institutions where we've had de-escalation teams. We had the psych unit, the same kinds of teams. What I'd like to say is, you said just a little while ago, reimbursement for behavioral health is not good. And, we're treating what the victims now, these people who come and do these awful things, and yes, we want the hospital safe, and we want people to feel safe. Shootings do happen in churches. There was a shooting in an ICU in Philly just a few weeks ago and killed a couple people. The deal is we need to figure out how in our system to have people believe that mental health is in trouble. And that these people, we need to change our reimbursement so that we're able to treat people who are out there. Some of them don't even know that they're mentally ill. We don't validate it. It's a stigma, but these are the people that are doing things, or people that snap. They could have had something else go on for them. But we've got to look at our insurance system and see what we can do to help people. And also try to have more equity in the community. You know, people say we're products of our environment. Well, if you don't feed somebody, you know, and they, long enough, you know, and they do see food, they're just gonna want to, they're not gonna act like me and you. So we need to look at the inequities in society and put a bigger focus on mental health, treatment, and places for people, housing. You all know it, especially here. We get patients that are admitted here, they have nowhere to go. There's nothing else for them, and we have these patients in our hospital, and then they talk about, oh, well, your bottom line, you're not meeting your bottom line. But we're also taking care of a group of people that if our insurance system were better, this would not be an issue.
Okay, so quite a lot said. We tend to, put up we recognize signage. We have metal detectors on the way in our entrances in some of our hospitals now. We have armed security presence. These are not the measures that are going to address what's causing, or the causation of what's happening in our workplace in healthcare. It's the norms, I suppose, of behavior have changed, have shifted. We need to recognize that as where we're working. That's throughout nationally, probably internationally. I don't want to get too far into that, but we have to realize as well the recognition of, as Dr. Winston said, our behavioral health, our support, our recognition of our mental health programs needs to be stronger in order to work with our society, and that we're able to prepare and treat and recognize those patients because it's more and more frequent. On the staff side, staff support, the supportive teams recognizing and de-escalation is definitely a tactic towards providing support for staff, having teams trained in recognizing those, have teams recognizing other patients or other scenarios that they're not participating in but been around, and intervening where they can, to prevent that crisis or prevent that from escalation is a tactic again, and that's training and more adaptation of that. I think we need to see stronger in our orientation programs for our staff coming in, our staff orientation, that we address this head on, and calling this out and saying this is something that we're here to support and develop, and we'll continue focus on that. So it's not solved. It's a real problem. I mean, we have, and to burnout, to how it affects our ability to retain, and I've had people leave because of they felt that the work environment, and they chose to change positions and jobs and career paths because of feeling that the work environment was not considered safe. They had family advised them about continuing to work on a particular unit in a particular place or a particular scenario because they felt that we were not providing a safe work environment. So we have definitely more to do. We can, again, put signage up. We can have policies, but it's really about practice. It's about supporting our teams more and leaning into the problem. And as again, your point about recognizing and having more support for our mental health programs throughout the state, throughout the city, throughout the country. And it also impacts our gun violence in our schools and other areas where we see these things happening. So I wouldn't say we're failing as leadership when it comes to that, but we're not, we seem to be not moving forward.
Thank you.
Excellent, thank you. What do you think, Dr. Naqshbani? We got time for one more? So it's either speed round,
Yeah.
or does anybody in the audience have any questions? Oh, I see a hand up.
Couple hands.
Is that Dr. Smith?
Come down.
Come on down.
It is.
So first, I want to acknowledge, as the interim chair of the emergency department, I'm extremely proud to see 3 emergency medicine physicians and colleagues on the panel. But I wanted you to talk quickly about interprofessional teamwork during crises. And crises doesn't have to be COVID-19, but the strain on the healthcare system. And what are some of the initiatives that you've done between doctors, nurses, ancillary staff, social workers to build interprofessional teams? Thank you.
So I'll take a stab at that one. I think one of the most important things that we are doing is to emphasize the value of every single role in the healthcare delivery system. So whether you're working in finance, supply chain, you're a PCT, emergency management, everything you do contributes to that service that we are delivering to the community. Historically in medicine, there was hierarchy. Right, so based on your title, you had a certain amount of power and recognition and status. I think we have to do away with that because quite frankly, and I'll speak as an emergency physician, I couldn't deliver care without my team. And there were more than one occasion when the clerk said, Dr. Scott, you need to check on that patient. Or the EVS worker said, hey, Dr. Scott, you might want to check on the guy in the corner. And truthfully, on several occasions, those staff saved someone's life, right? And so the most important thing, I think, is to make sure that every member of the team knows their value and that we respect each other's role in the delivery of care. And so once you create an equitable, inclusive environment, and it's not easy, right? Because people in power want to maintain their power, right? So I'm not saying that this is an easy thing to do, but if you're able to create an inclusive, diverse team where every member of the team is respected for the role that they play, then you're going to create a winning team. And for me, that's my approach to creating a better, more cohesive team.
I would just add to it, people tend not to develop better habits when they're stressed and under pressure and a crisis, right? So it depends on the culture that you create during kind of blue sky times, during normal times, right? Do you have multidisciplinary rounds? Is everybody, treated equally, respected, able to speak up and have the psychological safety to speak up? Are there quality improvement initiatives multidisciplinary? Are people working together to make things better? And if you have all of those things, and I'm a big believer in team steps training, so people have the tools, the language, people know, when other people are using team steps tools, that helps you going into the crisis, right? That this is just how the team works.
Excellent. Dr. Winston?
I didn't plan to comment. I was saying next. I'm trying to help Rami be a timekeeper. However, we need to level the playing field. If you're going to be a team, your team. I'm someone who uses the word we more than I, or mine, or theirs, or yours. And when people feel value when you say we, because they feel that they're equal to you. I can remember when I started in leadership, I didn't wear a name tag because I didn't want people to see me as that person. And that's what we need to do as we team build. The nurse, the clerk, the environmental service worker, the physician, their level. People have different skills that they bring to the table, but it's we.
And it's about culture, yeah, and correct statement. Our culture is not in crisis. Our culture is built when we're, when it's our normal other 364 days of the year when we're doing our work, having a respect and the feeling that you can contribute and speak up and contribute to that. So it's ultimately about not shifting focus about the safety, taking care of our patient or the patient in front of you, or the situation in front of you, and not letting that crisis divert the team away from that. So everybody's got a role to navigate that.
Thank you. I think we have time for one quick question and some quick answers. So please go ahead.
Okay, good morning. Okay, so my question is, what is the healthcare industry as a whole doing to address all of the problems that were described here? For example, you mentioned Baxter and how the hurricane affected Baxter. But several years ago, when the hurricane hit Puerto Rico, Baxter was affected. At that time, we had a crisis in the healthcare system again. And just last year, when Baxter got hit again, it's the same crisis. Nothing was done. Baxter is one of the largest vendors in healthcare. Why wasn't something done after that first hurricane to make sure that there was some backup system there? And similarly, last year, 90% of the healthcare industry couldn't bill at one point. There was just one company that was handling billing for healthcare, throughout the country. What is the industry doing to make sure that those sorts of things are anticipated and can be avoided in the future?
Not enough.
Yeah.
I think reliance on a single source of just product and solutions has, we positioned ourselves poorly because we're trying to favor ourselves over, sole source advantage on pricing, and it's given us maybe an advantage economically because we're trying to pay our bills and match our reimbursement programs deficits. So, but that leaves us vulnerable to instances like this, like a company or a geographic location or an IT solution that, just single source for clearinghouse for authorizations, as you were referring to, and shifting to another vendor, keeping an alternative and a backup system in case of cybersecurity. So having alternatives, but alternatives cost money. So that's, I guess that's the.
Yeah, I think it's going to require policy outside of the healthcare industry to manage this challenge, right? So there's a capitalist drive behind us using the same vendor for the same services, and I believe it's going to really require legislation outside of the healthcare industry to help manage that.
Well, thank you so much. Outstanding panel, amazing discussion. It was really great to hear your perspectives, your thoughts about how to lead the organization, how to build the process in place to lead the staff in such crisis. And I love what Sandy mentioned, that the question is not if we're going to get a crisis, it's when we're going to get a crisis. And it's very impressive how all those organizations work together, building a process in place to make sure that we are providing our mission, which is serving this community in challenging times. Thank you so much. Thank you, Cindy and Jamie, for leading a really great discussion, and I appreciate you coming to Downstate. Thank you very much.